Hi, this is Dr. Ryan Kazemi. When considering implant replacement of missing teeth in the posterior maxilla with three-dimensional bony defects, there are several treatment options that are possible. Today, I would like to discuss a bidirectional augmentation technique for double-arched posterior maxillary vertical defects. The maxillary bone can undergo various resorptive patterns depending on its location and etiology, such as trauma, loss of bone from periodontal disease, pathology, or denture use. Looking specifically at the posterior maxillary defects, the bone loss pattern may be either purely vertical, horizontal, or a combination of both. One particular pattern of vertical bone loss that I'd like to discuss today is called the double-arched posterior maxillary defect, which has two components: a deficiency from the sinus aspect and a deficiency at the crestal level. First is the pneumatization of the maxillary sinus upon loss of posterior teeth, and the second, the crestal bone loss, specifically vertical bone loss, from periodontitis or pathology. Together, they characteristically result in a double arch deformity, superiorly from the sinus and inferiorly from the crestal bone loss, with normal levels of bone anteriorly and a somewhat normal level of bone at the tuberosity region. So here's a patient who presented with severe periodontitis involving tooth number 14 and missing tooth number 15, lost earlier for the same reason. The tooth was extracted and then simply allowed to heal to regenerate soft tissue and achieve a healthier local tissue. And here's the patient at 3 months with a broad alveolar width and an arch deformity at number 14, 15 sites. And the CT scan shows a significant vertical bone loss with both components of a pneumatized sinus and crestal bone loss with about 3 to 4 millimeters of remaining bone height. This is a classic double-arched posterior maxillary vertical defect, again with components of both a sinus and ridge deficiency. For implant replacement, we know some type of a vertical bone augmentation is necessary. And for this, we have three options. The first option is to perform a sinus lift and position the implants at the existing ridge level. This, of course, will result in a very apically positioned implants and a long clinical crown, which has biomechanical disadvantages, as well as poor hygiene access for a patient with possible peri-implantitis complications. The second option is to only augment the ridge and achieve an additional 3 to 5 millimeters of crestal bone height. With this approach, we will still have to place relatively short implants, which in type 4 bone and elevated forces of occlusion in this area may have a more risk of failure. The third option, and probably the most ideal, is to augment both the sinus area and the ridge defect, which will allow us to position the implant coronally at a more ideal level with better biomechanical features, as well as allow placement of longer implants with more bone interface, better stability, and hence improved longevity. The sinus and the ridge reconstruction can be done at the same time with excellent predictability following a bidirectional bone augmentation technique. The technique for bidirectional bone augmentation involves a single-stage sinus lift and placement of an autogenous block shell with an interpositional particulate bone in the gap. The arched shape of the ridge provides great stability for the block shell and restoration of the ridge height. The critical factor for success in this technique is presence of an adequate amount of soft tissue and a thick biotype for proper closure. So if necessary, a connective tissue graft may be done initially to create a thicker biotype, allow it to heal for about 6 to 8 weeks, and then perform the bone augmentation. In this patient, we had rather a thick tissue biotype and adequate amount of tissue for flap advancement and repositioning, hence the connective tissue graft was not necessary. So we'll access the site with a crestal incision and a generous flap to access the ridge and the lateral aspect of the maxilla for a conventional sinus lift. And here we see the vertical defect with good bony height at the distal and proximal aspects, creating the described arch form. In preparation for bone harvesting, we'll first measure the length of the desired bony shell. We'll harvest the bone from the ramus, and since we only need a cortical shell, we can keep the width of the harvested bone to minimal. We'll then perform a sinus lift using a lateral window approach. The harvested cortical shell is then positioned directly on top of the ridge using the anterior ridge and the tuberosity part of the arch defect for a positive support, and then fixated with 2 screws. We'll also place several perforations in the cortical shell for increased vascularization. For the sinus lift and the interpositional gap, we'll create a particulate complex using a mixture of autogenous particulate bone from the ramus and mineralized freeze-dry bone. Prior to the particulate grafting, we'll mobilize the flap using periosteal scoring to assure a passive and a tensionless closure. We'll then place the particulate graft in the sinus and between the block shell and the ridge. And finally, layer some bioos superficially, which has less resorption and hence helps to preserve the buccal form. A resorbable membrane is then placed over the sinus and the ridge graft, and then we'll proceed with the flap repositioning and closure. Multiple horizontal mattress sutures and running sutures help to approximate the tissue. Here we are at 6 months, noting an improved tissue architecture vertically and better alignment with adjacent teeth. And here's the x-ray at 6 months and the CBCT showing the abundant amount of vertical bone for implant placement. From the coronal perspective, we can now plan precisely the implant size. Here selecting implants from 5 to 6 millimeters in diameter and 13 millimeters in length. And here is our before and after, showing not only an increased height of bone, but also restoration of the ridge deficiency with better alignment with the occlusal plane. For placement of the implants, a crestal incision is placed and the flap is raised to reveal the ridge, which is now restored to a more appropriate height. The fixation screws are then removed, the surgical guide is positioned, and our initial implant sites are prepared. The guiding pins are then placed to confirm the trajectory and the position. Implants are then placed, and because of the cortical nature of the bone graft at the crest, they have great primary stability. So we can proceed with a single stage placement of the implants and the healing abutments. So here are our implants with a more ideal positioning at the crest, well aligned with our plane of occlusion and the adjacent teeth. And the final restorations with proper crown length and tissue level for improved function, stability, and access for an effective hygiene. The bidirectional maxillary bone augmentation for this type of defect allows ideal placement of dental implants with a more favorable crown to implant ratio, as well as improve aesthetics, function, access for hygiene, and longevity.